This time we're going to jump right in because I know the time is getting away from us, but oh my God, this has been some good pillow talk on tonight. But our next pillow talk presenter, and which is going to be the good one, because this is something, it's a hot topic because we've been hot, Lord Jesus, is Dr. Shenika Welch-Charles, a native Tennessean, originally born and raised in Nashville. And as a recipient of an academic scholarship, she received her undergraduate degree at Tennessee State University before matriculating into Meharry Medical College for medical school. She completed her medical education at Meharry Medical College with honors and graduated in 2007. And then she remained at Meharry for her residency training until 2011 and began her private practice career in 2011 in Fredericksburg, Virginia. Then she returned to Tennessee in 2015, taking a job at the University of Tennessee, where she currently practices. Amen. Dr. Welch-Charles has been married to her husband, Lance, for over 13 years. And they have two amazing, ambitious, and inquisitive daughters. And I dare not call their names because I can't pronounce them. In her spare time, she enjoys crafting, dancing, fitness, and sewing. I present to you Dr. Shenika Welch-Charles, of whom will be speaking to us on menopause. Let's say amen as she comes. Dr. Charles, we're in your hands.
Sorry, I'm trying to share my screen.
Oh, okay.
Okay.
While Dr. Charles is on, oh, there you go. No,
No, is
okay.
it sharing?
No, it's not.
Okay, I'm going to keep working. You can go ahead and do it.
Okay. I just want to let you all know that we have someone else on the line with us. She's not a part of our panel, but we have Dr. Maureen Siebert with us on today, and she's an assistant professor of nursing at NYU College of Nursing, and she is the founder of Fertility Goals, a fertility coaching company to help women plan their path to motherhood. So I'm so glad that she's on tonight too. So if something comes up about fertility, she is here to help us also, but we're so excited about Dr. Shenika Welch-Charles. And lady, we got some girl power going on here tonight. All of these professional women.
I am. Can you guys still hear me?
I can hear you.
Okay, I'm super excited too, but I am not savvy and I don't know how to exactly share my screen. Wait, I think I got it. 1 second. Can you see that?
Yes.
All right, here we go. Good evening, ladies. So happy to be here. Thank you so much, Ms. Sheila Hamilton, for inviting me. As she just spoke about Dr. Maureen Siebert, we crossed paths when she was here in Knoxville a few years ago. A very special person who actually gave Mrs. Hamilton my information to allow me to come in and speak to you ladies tonight. As she said, this is a very hot topic. This is something that I speak on many times a day. I do feel like a lot of things have come up in a lot of the talks that some of the prior speakers have spoken on tonight. And a lot of it is just about women not being able to speak up and say things. You know, we're getting to that point in our lives where women have questions, and no longer is the day where we sit behind and just try and figure it out on our own. Like we talk about it and we're starting to ask questions and we want to know answers, and women are just living longer. And so some of this information is all brand new because people haven't gone through it. And if the ladies that are in their life that have gone through it didn't talk about it. And so that's how I came up with the topic. Here we are, aging as a woman, the unspoken truths. And I followed that with this very, very classic statement: you aren't crazy, it's just menopause. And the reason that I say that is because as so many people that I see on a day-to-day basis think that they're going crazy, and menopause is not you going crazy. It's just your body changing. And the purpose of this talk is to kind of help you through that. So we're going to go now. I think. Here we go. Let's see. All right, disclosures. I don't really have any, but I do want to say, although I am a medical provider, this presentation is not intended to offer any specific medical advice, mainly just to serve as an informational session so that you can have some information or questions, concerns that you can take back and address with your own personal medical provider. So just a little bit more about me, a little quick short bio and just a few pictures here. Who am I? I am a Christian first and foremost. That is the foundation of who I am. I believe that I am in this position to do what I do because this is where the Lord wanted me to be. He is invited into each and every one of my patient encounters, especially into my surgeries. We do these things together, and I pray to be a mouthpiece for him in helping women navigate their lives. Secondly, I'm a wife. That's my husband, Lance. We actually just celebrated our 14th wedding anniversary on yesterday. I am a mother. These are my two daughters. That their names are Daenerys and Briseis. And I am a daughter. The picture in the middle with the lady in white, that is my beautiful mother who raised 4 girls all by herself. And one of us is not pictured, but if you look right below, I am also a sister. There are the 4 of us together. I am a physician. So again, I'm an obstetrician and gynecologist, and I love women's health, and it is who I am to my core. I am a 2-time breast cancer survivor. So that's what that picture over on the right is indicating there. That is my sister that's right beneath me. She too had breast cancer, and that was after one of our breast cancer walks. And more importantly, I'm a woman, but a perimenopausal woman. So that entitles me in and of itself to give more information about this topic. So the number one question, why has no one ever told me this stuff before? It really just all began with your period. And I always ask this question to women, like, how many of you even had a period talk with your mother or caregiver or whoever it was that raised you? And it's astonishing to me that many women never did have this talk. There was some sort of passing off some pamphlets or a book, or just dropping little nuggets around, but actually talking about it out loud is not something that a lot of women have had to happen in their lives. And because of that, that's why they go through this whole period and transition from starting their cycle, going into perimenopause, menopause with unanswered questions, because the questions have always been unanswered from the very, very beginning. So let's just talk about the hormonal life phases of a woman. It starts with puberty. You start out with your menstrual cycle, and then you start to go into your reproductive years, and we'll just call that, for the purposes of this talk, pre-menopause. And then after your reproductive years where you've had your babies, you're in that transitional zone before you actually have gone into menopause. We call that perimenopause, meaning you're around the time of menopause. Then you actually enter menopause. And then after menopause, you then become postmenopausal, meaning after menopause. So I found this cute little slide, and it's hilarious because she says, oh, I understand it now. Menopause is just puberty's evil older sister, because just as your body is constantly changing as a woman, you finally get used to the whole puberty piece. And then just when your body is getting to a point where you're accepting this is where I am, it starts to change all over again, and you have to relearn everything that you thought you knew. So again, the menstrual cycle. This is just a diagram to show the main things I want you to take home from this diagram are just these hormonal levels, because when we're talking about any type of hormonal changes, with beginning with the menstrual cycle, but most definitely going into perimenopause and menopause, we are talking about the changes in these hormones here. So your body is starting to, as you're starting with the menstrual cycle, FSH and LH are driving that. When you ovulate or you release an egg from the ovary, that is what's being shown here with the ovarian cycle. All these different changes are happening all at the exact same time at different phases. And you can see here days 0 to 28 of your menstrual cycle. And so these hormonal fluctuations are the driving force behind everything that defines us as women. So what exactly is menopause? This diagram here sums it all up. Some people may have some of these symptoms. None of these symptoms, all of these symptoms, some of these symptoms that come and go, and then it just when you think they're over, they come back again. But the actual definition of menopause is the natural, permanent cessation of menses for 12 consecutive months with no other reason for not having a period for 12 consecutive months. And that average age is usually somewhere around 51.4 years. It's affectionately known as the change. And really what's happening, if we refer back to that other slide with the hormones, is that you're getting a sharp decline in the amount of estrogen that you have circulating throughout your body because the ovaries at this point are becoming non-functional. And so some of the symptoms that you have are these over here. The ones that I'll highlight the most, and we'll talk a little bit more about, we have this brain fog that can lead to anxiety, depression. We have hot flashes, night sweats. I hear women all the time talk to me about, yeah, I smell old. There's changes in their body odor. They feel like they smell, and these are their words, not mine. I smell like an old person, whatever that smell is. Loss of libido, the periods start to get regular, vaginal dryness, itchy skin. All these things are part of that whole menopausal cascade. And it doesn't have to happen. Like some of these symptoms can start to happen as you are in that perimenopausal time frame. So what are the stages? We've kind of alluded to them before, but we'll go into a little bit more detail. Menopause, you have to laugh or you just end up crying. So we talked about the stages here. So now let's put some ages behind it. So in premenopause, we talked about this. This is when women are in their reproductive years. So usually this is from puberty until you're in your mid 40s. This is when you're the most fertile. This is when people are having their babies and deciding if they are or if they aren't. Then you enter perimenopause. So this is in your mid 40s until you actually transition into menopause. The fertility starts to go down at this point, but it is not impossible. So there was a reference made to Janet Jackson before. Whether she did those things naturally or if she had assistance with that, we'll never know. But fertility does start to go down once you enter the perimenopausal age range. Menopause, we talked about, average age is 51.4. So usually at this point, you have completely stopped having periods and therefore your fertility is over. There is no more chance for you to conceive on your own. And even if you still have your uterus in place, that's another discussion for another day, but you still do have the capacity to carry a child, but your ovaries are not releasing eggs for that child to potentially be biologically yours. And then postmenopausal is after you've been through that phase of menopause for 12 months for the rest of your life. And so at this point, usually you're not having many more of those symptoms that we talked about on that other slide. They're practically gone at this point. They're usually the most intense right here during the menopausal time frame. And so this is just a diagram here that is just illustrating what's happening to the estrogen level. So you're right up here, way, way high in that premenopausal. And then as you start to kind of get closer to the menopausal phase, that estrogen starts to go way, way down. So this is just another slide here that just talks about premenopause, and we don't really have to go that much more into detail. It's pretty much the same stuff that we talked about before, but the main thing is that this is your most fertile phase in your life. The perimenopausal phase is when we start to get some of those transitional symptoms to creep into play. So usually the number one thing in the perimenopausal age group women start to complain about are changes to their periods. The periods usually start to become rebellious. They get extremely heavy. They become extremely unpredictable in some women. And sometimes the cramping and the flow really, really becomes dramatic. If you are used to having like 3 to 5 day periods that are medium flow, they can start to become longer, 7 to 10 days. You're starting to have heavy flow. You're saturating your pads and your tampons. Women are having accidents through their clothes. passing large clots, all of those things. That usually is what brings a lot of women into the office when the periods start to change. And after we complete our entire workup, if there's nothing else that we can blame all of that irregular bleeding on, then at that point, we know that we're dealing with perimenopause. Hot flashes may or may not be a thing. Mood swings definitely start to creep in a lot of women. And I get lots and lots of complaints about the loss of libido. And that could be due to so many reasons, but this is starting to become more and more common. So again, we talked about why this happens, and it's because the estrogen is starting to decrease. And so because the estrogen is starting to decrease, then we're having fluctuations in our menstrual cycle, going back to the original slide, because the menstrual cycle relies on very, very synchronized patterns and timing of the hormones in order for it to be synchronized. So if there are any fluctuations in the hormonal levels, it throws off the menstrual cycle, which ends up throwing off the periods. Postmenopause, 12 straight months with no period. And we can't explain it by any other reason. So there are some women who I've seen that are nowhere near age in postmenopause, but they may think that they've gone through it because they're not having periods. That requires a very special workup to ensure that there is nothing more going on, because in general, it's probably not postmenopause if you're much younger than that, and you really need to see someone if you're not having regular monthly cycles. So again, we bring the hot flashes back into it, but now at postmenopausal, not just a decrease in libido, intercourse starts to become painful. Some women start to notice that they're having a hard time holding their urine, whether it's when they cough, when they sneeze, or if they're just getting the sudden urge to get to the bathroom, and by the time they get there, it's just too late. And a lot of this is related, again, to these changes in hormones. So low estrogen, the FSH, which is that hormone that usually drives the estrogen, actually does the opposite and comes really, really high. And then you start to get changes in the pH of the vagina. So in addition to having painful intercourse, you are also more prone now to having vaginal infections. So other things that low estrogen can make you more susceptible to as a postmenopausal lady is osteoporosis, which is thinning of the bones. Thinning of the bones can become very problematic because as you continue to age, they just continue to get thinner if there is no treatment in place. And this is what puts a lot of women at risk for fractures, hip fractures, wrist fractures, all of these fractures and bones that you hear people talk about in older people. It's usually related to osteoporosis. Heart disease, because estrogen is protective of our heart when it is normally circulating, and high blood pressure kind of falls under that umbrella of heart disease. So it all still works with the estrogen level. Things you can do, just see your doctors on a regular basis. Make sure you try your best to have some healthy daily habits, exercising, light arm weights, things of that nature, swimming, water aerobics. These are all very, very important things that could be easily done by a lot of women. And then any herbal supplements, vitamins, vitamin D, calcium, things of that nature, those are all very helpful. So there are other types of menopause that aren't just the natural progression of life. And so we'll hit on those here briefly in these next couple of slides. But first, we'll have the little warning. Due to the influence of hormones, I could burst into tears right now or kill you in the next 5 minutes. A lot of women just have these weird, sharp mood swings that go from one extreme to the next. And a lot of times they're not always aware of it unless they have people in their home that give them looks to remind them that you are not okay right now. And so, I think that, having open, honest communication with the people who you live with, especially if you're going through this transition, is ideal. Not snapping their head off if they come to you and say, hey, I think you could have probably said that a little differently, because everybody, if you're going through this, then everybody in your home is sort of going through this too. And so we just kind of want to make sure that we're mindful of our mood swings. So premature menopause means that you go into menopause before you are 40 years old. And this is rare. It affects about 1% of women, and there are different causes of it. And they're listed here. Sometimes it could just be genetics. This is something that happens to all the women in a particular lineage. Some autoimmune diseases can be the cause of it, some infections, unhealthy habits. And then, the more common, especially as more and more women are being diagnosed with breast cancer at earlier ages, radio or chemotherapy are big culprits for that. And it's not just breast cancer, but any type of chemotherapy, especially drugs that can inhibit, or because chemotherapy in theory is killing dividing cells. And so if you have dividing cells in your ovaries, which are helping with your babies, they could kill those before you even get a chance to get started. And then this term here, oophorectomy.
Yeah, let me know when you get done.
Then this term here, oophorectomy, just refers to having
So
an
what?
ovary removed. So if you have had to
Okay,
have
all
one
right.
or both ovaries removed, there. Okay, I don't know when I got muted. I'm sorry. It just gave me an alarm that I was muted.
We didn't miss anything. Okay.
Okay, perfect. Okay. Some of the signs and symptoms of premature menopause are the exact same ones of menopause. So you get hot flashes, vaginal dryness, loss of libido. But think about how detrimental this is to a woman who's under the age of 40. Like this is a big deal. And as I put in that initial slide, I'm a 2-time breast cancer survivor. The second time I went through breast cancer, I had to do chemotherapy. And I was 34, 35. So that was really tough to have to deal with hot flashes and vaginal dryness and painful intercourse. I mean, that's not something that I ever even wanted to wrap my mind around, but it definitely was an experience that has allowed me to be more empathetic to women when they have this issue. But that's a really hard pill to swallow when you're not at that stage mentally to be prepared for that. And the same old effects here in osteoporosis, heart disease, incontinence, but then we have infertility. So lots of women are waiting longer to have their children and they're not having their babies right away in their 20s. So if a woman goes into premature menopause, then that could be a big blow, especially if she just is desirous to have children. So hormone replacement therapy, herbal supplements, these are some of the things that can address that. Surgical menopause, we hinted on it before, having your ovaries removed for one reason or another. Just having one ovary removed will not put you in menopause, but if both of your ovaries are gone, you will immediately become in menopause. And there are different ways to have those removed, different reasons that they have to be removed. But the bottom line is, if the ovaries are gone, both of them, you automatically become menopausal. And then we talked sort of about this induced menopause, and it's kind of going back again to the chemotherapy and things of that nature. So what are some of the symptoms? So beware of the menopause fairy. She steals your figure, then she steals your sleep, then your mood, your patience, your eyesight. Finally, she eats your brain. And all she leaves you with is a lousy mustache, a muffin top, hot flashes, itchy skin, 10 million moods, a dodgy memory, and an endless need for naps, coffee, wine, and carbs. Sorry, guys. Menopause, low levels of estrogen, decreased estrogen production by the ovaries, which stimulates low levels of testosterone. So this hormone, testosterone, we haven't talked about up until now, but testosterone it's the male hormone, but it's circulating in our bodies as females as well. Nowhere near the levels that it is circulating in the male bloodstream, but we derive our testosterone by the production of estrogen. So the testosterone a lot of the times helps to drive our sex drive. And so when we transition into menopause and the estrogen starts to decline, then the amount of testosterone that we were getting to circulate in our bloodstream from the estrogen starts to also decline until eventually we don't have much of that left over. And so that is part of the driving force behind that decreased libido, in addition to the fact that a lot of the times the tissue in the vagina becomes extremely thin and intercourse becomes painful and uncomfortable. So again, that drives a lot of the decline in the libido. So we've already talked about the mood swings, hot flashes, and the irregular cycles. So these are the 7 dwarfs of menopause: hot flashes, night sweats, sleep problems, vaginal dryness, depression, anxiety, and weight gain. So the hot flashes, they are the most common symptom of menopausal changes. 80 to 85% of women are going to have hot flashes, and they're usually more common at night than they are throughout the day. What it feels like is a sudden feeling of heat. Usually it just kind of rises up here in the middle of your body, and it goes up through your neck and chest, and it just shoots through your face and feels like the top of your head is going to blow off. It usually lasts for about 2 to 4 minutes. And afterwards, you're probably a sweaty mess and just all out of sorts. And so these can happen 1 to 2 times a day, or even one per hour at night. Usually once they start, they last about 6 months to an average up to 2 years. Unfortunately, there are some women who continue to have these even past their postmenopausal time range, but those women are rare. Eventually, most of the time, these symptoms will go away. So while you're having the hot flash, you may also have that intense feeling of just redness and heat in your face. Your heartbeat may get really, really rapid. You start to perspire and sweat. And then after that, the sweating, you end up having cold chills because you've been sweating so much, and now your body temperature is trying to cool you back down. So just a little bit of science behind a hot flash. I don't want to get too nerdy on you here, but the reason that this is happening is because your body really is trying to help you out during this whole process. So you have an area in the brain that regulates your temperature. And so when it senses that, your body temperature is heating up, then it starts to do things to your blood vessels to try and help cool you down. But really it ends up causing the actual hot flash to become worse. So it's like the hot flash really is it's kind of sad because your body is trying to help you, but in the end, it really just makes it worse. So some of the things that trigger hot flashes that you should keep in mind are the highest is stress and emotional situations, external heat. I mean, we just are coming out of a really, really hot summer. So when it's really hot outside, you can expect to have a lot more hot flashes. Being in confining spaces, alcohol, 20%, and then caffeine, because these are all things that can a lot of times increase your heart rate naturally. So if your body is sensing that you're getting this change in your heart rate and your body temperature, then you get locked into a hot flash. Night sweats. This is the term that we give the hot flashes that occur at night. We talked about this. You get intense sweating. The thing is, you wake up because you're freezing cold most of the time because you've sweat through all of your pajamas, all of your clothing, all of the sheets. You're waking up. And usually these can happen 1 to 2 times a night. The issue with these night sweats, aside from the fact that they're inconvenient, is that you're waking up multiple times a night. And so you're getting really, really improper sleep, and you're having these restless nights. And so the next day you end up very irritable. You have a really hard time concentrating. You're tired, and then you're moody. Sleep problems. These are very, very common with fluctuation of hormones. You're laying in the bed, you're exhausted, but your mind will not shut off and you cannot go to sleep. And so even if you do fall asleep, you end up waking up at like 3 or 4 in the morning, and then you can't go back to sleep until it's time to wake up, and then you're exhausted. So again, you end up with feeling extremely tired the next day and unable to really get through your day. And that a lot of times leads to irritability. Some women even develop restless leg syndrome. So you're just, feeling this constant need to move around and twitch at night. And so that keeps you up. Some of the things that could be helpful, we can go back to our very, very first speaker, and she gave us those muscle relaxation techniques. So sleep hygiene, the cognitive therapy, the relaxation techniques, and some medications are helpful for the sleep problems. The sleep problems a lot of times during this time frame usually don't respond as well to melatonin and things like that over the counter, because this is more of a chronic situation. But usually once you get out of it, then you can come off of any other prescribed medicine. So if you've tried the melatonin, if you tried other things and it's not working, then you might want to talk to your primary care doctor to talk about medicines for sleeping. We've mentioned this several times, but the official name that we call it is the genitourinary syndrome of menopause. And again, we're back to our decrease in estrogen. And so it ends up causing the tissue of the vagina and the urethra to become very, very thin, very, very fragile and dry. And the symptoms a lot of times can feel like you're having a urinary tract infection or you're just having pain during intercourse. A lot of times because of that pH change we talked about, you're more prone to infections. So you may have itching in your vagina, burning. You have discomfort with any clothing that fit a little tight down there just because the tissue is just so affected. You can even have light bleeding or irritation when you go to urinate or go to the bathroom. Toilet paper, a lot of times, if it's really bad, can irritate. So like we said, 17% of women will experience vaginal dryness. 90% of postmenopausal women experience the vaginal or the vulvar dryness. And only 25% of these ladies receive therapy. And a lot of that reason is because that nobody's asking them about it. And because nobody's asking them about it, they don't volunteer it. And so they end up trying all of these over-the-counter remedies that a lot of times don't work because the root of the issue is the fact that we no longer have estrogen circulating. Mood changes, new problems with mood, sadness, difficulty concentrating. You lose pleasure in things that normally brought you a joy. And then you're either sleeping too much or you're not sleeping enough. And this is higher. These mood changes are higher during the transition between the pre or the postmenopausal woman. Weight gain. This is a biggie. It happens right in the very same spot for most women, right in the middle. And so that we're calling that increased central fat distribution. There was a study called the SWAN study that went over 6 years, and it showed that women will gain over this 6-year period at least 6.39 pounds and 5.7 centimeters increase in their waist circumference. The rate of the waist circumference did, however, decrease after 1 year, but still there was 5.7 centimeter increase. But your fat mass continues to increase. Bone loss or osteoporosis worsens as you advance in age. The bone loss at the spine usually begins 1 year before your final menstrual period and is usually at 10% by 6 years in menopause. Things that can help are weight-bearing exercises, calcium, vitamin D, and surveillance with bone scans or DEXA scans every 2 to 3 years. So we've talked about menopause, perimenopause, all the things. So now talk about what we can do to manage it. When you are going through this situation, you have to first decide if you want to try and fix it with the hormonal route or the non-hormonal route. Obviously, our issue is because we don't have the hormone. So it would be more of a knee jerk to say, okay, well, fine, give me the hormone back. But when you ask for the hormone back, you're also introducing the possibility of risk and complications that can come with that, which is why a lot of women shy away from those hormonal therapies and move towards non-hormonal approaches. So when we talk about hormone replacement therapy, we abbreviate that HRT. Estrogen, again, is the hormone that needs to be replaced. If a woman doesn't have a uterus and has had a hysterectomy for some reason and the uterus is gone, then that is all she needs. But if the woman still has the uterus in place, then you have to also give progesterone in addition to the estrogen to balance out the uterus so that you don't increase the chances that you'll get cancer of the uterus. And the whole goal of hormone replacement therapy mainly is to reduce the hot flashes. So different types of ways to have hormone replacement therapy. You can use pills, you can use patches, rings, creams, oral and vaginal routes. These are all different ways that you can get back estrogen into your system. And on non-hormonal management, the same goal is there to reduce the hot flashes and to reduce the genitourinary syndrome symptoms. And so there are some anti-anxiety medications that we use off label to help with the hot flashes, just because they work on that mechanism that we showed of the picture of the brain to help decrease the response that's going on. And so Effexor is a very common one. Prozac is another one. Brisdale is pretty much Prozac, but it's the FDA approved version. And then Veoza is a new medication that is now approved for hot flashes in women. Because it is new, it is really expensive, but it is very, very effective. I have a woman who is unfortunately still having hot flashes, and she is 78 years old and on a very, very fixed income. But her husband told her that if she needed that for her quality of life, they will work that into their routine. And he is doing that for her. And she is doing so much better with that medication. For women who are just having issues with the vaginal piece and they're not having hot flashes, then there are some suppositories that can be used that are also non-hormonal. Intrarosa is the one there. And then there's another medication, Osphena. But let's not forget just plain old lubricants. I mean, lubricants are a good place to start. And one of the cheapest lubricants that we don't always see as a lubricant, but we probably all have in our kitchen, is coconut oil. Coconut oil is natural. It is very cost effective. A little goes a long way, and it does not make you more prone for any vaginal infections because it's all natural. There are lots of other alternative therapies that are out there that that people have tried: foot reflexology, acupuncture, meditating, aromatherapy, massage therapy. I mean, there are lots of different things that could help in some instances, but the things that are really going to, if you're really having the severe structural issues, like the issues with the thinning of the vagina, these things probably won't be as effective. They probably will work more for those hot flashes and night sweats, but the skin changes, they are probably going to at some point require some estrogen therapy. And I think this is just the same slide showing the same information on a different slide. And so we're kind of coming in on the end of it here. So some of the ways that you can cope: hot flashes and night sweats. If you smoke, stop smoking. Smoking makes hot flashes worse. If you're having trouble quitting smoking and you're at the point where you feel like you are ready to quit, then you can talk to your healthcare provider and they can give you some information or some tools or some medications to help you stop smoking. But that will definitely drastically reduce your hot flashes. Sleep problems. Try to go to sleep and get up at the same time every single day if you can. Try to avoid stimulants in the afternoon like caffeine. Also try to limit your alcohol intake. We talked about the sleep hygiene, the relaxation techniques, all of those things. Depression, do your best to stay active. Exercise, that's been spoken on tonight as well. We talked about how the kids who were making C's ended up making A's just from just adding in a little exercise. It really does help to improve your mood and give you just an outlet. Also, support groups for other women that are going through menopause are really helpful, just because a lot of times, we talked about this, people don't talk about it at all. And so talking to other women who are going through the exact same thing allows you a portal to discuss these things. And then you don't feel like you're alone and you have other people that you can talk to when you have a new symptom to pop up. And then with the vaginal dryness, again, vaginal lubricants are really, really helpful. Some of the ones that, most of the ones that are water-based are great initially, but a lot of the times the water-based ones you'll have to constantly reapply. So if you can find a silicone-based one or just that coconut oil that we talked about, those usually are going to help you the most when it comes to the symptoms of the vaginal dryness. And finally, being a hottie at 50 means you still get postmenopausal hot flashes. And that is all. Do we have any questions?
No question? Oh,
I have a question. I was trying to unmute myself. I'm sorry. Yes, I have been going to my OBGYN and I am 61 and I still spot sometimes when I'm picking up or straining or maybe stress, and they want to do a biopsy. But they keep telling me I'm menopausal, but I'm still spotting, and I never went a whole year without a period. So what should I really be concerned about?
Have they done a pelvic ultrasound?
Yes, I've had the ultrasounds. I do have fibroids, and just this year they removed. They don't know. She didn't know what it was. It was about 3 inches long, and the doctor said it was a blood clot. But they don't. So I don't know. I haven't went back yet. So, and I'm still spotting in between.
Okay.
But I know it's some of it's from stress and lifting. I do know that.
And are you taking any hormonal therapies?
No.
Never?
No.
Okay. Well, I again, I'm not giving any medical advice, but I do feel that the biopsy is important. Even though you haven't gone 12 straight months without a cycle, like you said, you just spot, but you've not had a regular cycle. Is that right?
I've had regular cycles, but I just don't know. I never stopped bleeding to know if I was menopause. And they told me I am. They keep telling me I am. The doctor's telling me I am. I'm like, how do I know?
Did they draw labs to say that you were in menopause?
Yes, they said.
Okay. So if they drew the labs to say that you're in menopause, and also because just for your age alone, we can say that you definitely, if you're 61, then you should not still be having any vaginal bleeding. So I do agree with your provider that a biopsy is necessary. The concern and the reason for the biopsy is to rule out any potential uterine cancer. Anytime that you have gone through menopause and stopped having periods and you start having periods or spotting again, that's not normal. And especially if you're not on any hormonal therapies. And so the only way to know the concern with the postmenopausal lady bleeding is that you could potentially have some abnormal cells growing inside of your uterus, precancerous cells, or uterine cancer cells. And so the biopsy will be there to rule that out. Now, if you have the biopsy and everything comes back normal, then that gives you some leverage to pull back and you don't have to worry so much. And we can think that this could be more situational, but I do think that this is something that you need to keep going back for, because that is not normal. And we don't want you to, just because you're getting conflicting information, to just say, well, I'm just going to throw my hands up. Don't do that until you've had a negative biopsy.
Okay, thank you.
Felicia Washington had her hand up.
Hi, now this has been a lot of great information, so thank you for that. I wonder if you could talk a little bit to endometriosis and fibroid cysts and how that can affect a young lady and who might have even had to have a hysterectomy, or who can't have children in their marriage and different things like that, and like how we can you speak a little bit to that for me?
The endometriosis specifically, or?
Yeah, so endometriosis and the if you have because the effects of endometriosis, it causes a hysterectomy. And then as a young woman, how we are, how that might affect us as, now I'm not a young woman because I'm premenopausal, but how it might help that, because I had cysts on my fibroid cysts. I can't say it right. And so with that, they were so bad that I wasn't supposed to have any kids, but I did. I was blessed to have a son. It was a very hard pregnancy throughout that whole time, and both of us almost died. He was like 32 weeks. And so with all of that saying, I was blessed to have a child, but with the whole, nobody really talks about what endometriosis is and how traumatic that is and what that does to you mentally as a woman, and that not being able to be fertile, and those kind of things. And then I think I heard somebody say something about fertility. What would you do in the case of if I did find out at a young age that I had endometriosis? And they give you that whole long spiel of you won't have kids, all these things that are happening with your body, and then the whole experience of going through. And so sometimes you get to the point where you're just giving up on the whole idea of even having kids before you even get the surgery and all that kind of stuff. There's like you have to have the I can't even think of how it was, but the scrape done or different things like that, like all that. And that's very traumatic as a young woman growing up, and you're having to deal with that. And you get later on in life and you might want to have children, but you can't. Is there like, well, can you speak a little bit to that?
I can.
Okay, thank you.
Yeah. So and thanks for sharing, because that's a big deal, and just being transparent in that capacity, because endometriosis, a lot of people will say that term and not quite understand it, but doctors will even flippantly say it, well, it could be endometriosis, and then just kind of leave you there and not explain what any of that means. And so for everyone else who's listening, endometriosis is a very debilitating condition that can happen happens to quite a few women. And usually you won't know that you may not know that you have this right away. You will start your menstrual cycle like normal. And the classic signs that women with endometriosis will complain about are painful periods. Well, I mean, periods are painful, but women with endometriosis, their cycles are painful on another level. But how do you gauge pain? So everybody's pain is different, and so you don't necessarily know. So everyone who has cramps with their cycle will say, yeah, man, I have really, really bad cramps. And so if she's standing right next to a person who has endometriosis that doesn't even know they have endometriosis, they're like, no, but mine are really bad. Like, I can't go to school, I can't move, I have to have the heating pad, like I can't work, like it takes me out of commission when I am having these cramps. So aside from the cramps, you can also have really painful bowel movements, and you can have pain during intercourse. So that's just a really horrible and sucky existence if you're having pain all the time. And the thing that's happening with endometriosis is that instead of your menstrual flow coming down out of your uterus and into your vagina and coming out that way, it comes out that way, but then a lot of the times it goes backwards out of your fallopian tubes. And so the blood that's back spilling into your pelvis is now starting to attach to the top of your uterus, your ovaries, your bowel, other parts of your internal anatomy. And so every time you start to have a period and your ovaries are releasing all of those hormones, it starts to trigger some of those implants that have now been placed inside of your abdomen. And that's why that pain is so intense. And so it's pain on another level than just having the normal cramping that happens with the uterus. It's pain all in your pelvic region. And that's why it hurts for bowel movements. And that's why it hurts for intercourse. And you're constantly going in and you're telling your provider, I'm having horrible pain with my periods. And so an astute provider could say, okay, you know what? I think that this might be endometriosis, and take it to the next step. Instead of just dropping that diagnosis in your lap and leaving you there, then there are some things that we need to do to try and address the endometriosis. If we understand that the endometriosis is being driven by the hormones, then a lot of the times what we do is try and quiet the hormones. And so for a young patient who is experiencing this, who has gotten this diagnosis, then one of the things that we can do before even jumping into the operating room is putting them on a birth control pill, because the birth control pill will calm down that reaction, that ovulation, the menstrual cycle that's happening, keep those hormones from attacking those implants that are potentially in your abdomen, and make the pain stop. And so it ends up halting the progression of the endometriosis. And if you can catch that early and halt the progression of the endometriosis, then it doesn't have to be so severe to where it scars down your fallopian tube, scars down everything in your pelvis, and causes you to have infertility. Everyone who has endometriosis is not infertile. The thing is, it's just if it's gotten so far and you've gotten so much scarring from that, then it can affect your reproductive organs, because everything needs to be moving around and flowing in order for the eggs to get where they need to go, the sperm. And if you have all these implants that's scarring everything